Good evening, everyone, and welcome to another episode of Scoliosis Dialogues from the Scoliosis Research Society. This is Terry Ishmael from Shriners Hospital for Children in Philadelphia. And today I have with me Dr. Owoicho Adogwa, who's a neurosurgeon at the University of Cincinnati. He's here to discuss differences in outcomes in surgery and adult deformity between males and females. Welcome, Dr. Adogwa. We're really excited to have you today. Please tell us a little bit about yourself. Who are you? Where do you come from? What do you do? Where did you train, and why do you do what you do?
Terry, thank you very much for the invitation, and certainly to the SRS for the opportunity to have this discussion around scoliosis. Originally from Nigeria, spent some time in the West Indies, and came to Duke University many years ago as an athlete. Played soccer there, and then off to Vanderbilt University for medical school, and then back to Duke for residency in Rush and Chicago. I completed 2 fellowships, one in neurosurgery with Rick Fessler, which is a minimally invasive and adult complex spine fellowship at Rush. And then I subsequently went up to WashU in St. Louis. And really the impetus behind that was, when we did these deformity surgeries at Rush, they were mostly done minimally invasively. And I had several questions. Where do you stop your UIV? How do you treat pediatric patients? Is that a different population from adults? What are the outcomes in after pediatric reconstructive operations? And so WashU answered a lot of those questions for me. And after WashU, I remember having a conversation with Keith Bridwell. I asked him a single question, which is, how do you identify a UIV in patients with adult deformity? This is after 10 months of fellowship. And he said, Owoicho, it'll take an hour to have that conversation. At that time, I was fortunate that Pierre Roussely, who was in Lyon at the time, and he was discussing a very novel way of thinking about deformity, not so much focused on the PI-LL mismatch, but around where we do the osteotomies and balance the spine. So I went up to France for another fellowship. I was there for a few months. And then I rounded off back on the African continent with Hannibal Boachi.
Wow.
In a Focus Hospital in Ghana, which really rounded off my education. So I consider myself an honorary orthopod. I spent a lot of time with orthopedics, and certainly I've learned a tremendous amount. I think why do I do what I do? When I think about spine, whether you're a degenerative surgeon or a scoliosis surgeon, we're working on the same problem. How do we align and balance the spine? We have this misnomer with alignment and balance. And the key thing to keep in consideration is alignment is static and balance is dynamic. So whether the patients present with lumbar radiculopathy and a single level disease, multi-level degenerative problems, or more complex scoliosis problems, I believe that the treatments are really the same. How do you put the head over the hips, over the knees, over the ankles? How do you really balance the spine? I love what I do. I think we have an opportunity to really restore patients' quality of life and function in a way that most other subspecialties don't have the opportunity to. And certainly as a deformity surgeon, we're oftentimes the last resort. And it's really rewarding and a privilege to give these patients back the quality of life that they seek.
Wow, that's fantastic. You're certainly really well trained, and I love your impetus for doing what we do. That's kind of similar to how I feel about things. I'm a pediatric orthopedic surgeon, so I do not just spine. I also take care of kids with lower extremity pathology, fractures, etc. And that's really what's drawn me to everything that I've been doing over the last several years. That's amazing. So today we're going to talk a little bit about sex differences between males and females in adult deformity surgery. Those of us who treat children such as yourself and me, we know that there are some subtle and not so subtle differences in treating pediatric patients. We know that boys tend to present with slightly bigger curves. The curves may take a little bit longer in the OR and may have slightly less correction, higher blood loss, etc. But overall outcomes tend to be pretty similar. Dan Ciccato, Dan Hedequist, and Lori Carroll, had their study in the mid 2000s, which kind of put this forward. But I know that you published on the differences between the sexes in adults. So why don't you tell me a little bit about your experience and also your papers?
Yeah, so I think when you think about adult deformity and the sex differences that exist, without question, there are some sex differences, and we're actually learning a lot more. And I'll sort of get into some of the work that we're doing in the laboratory that sort of reaffirms that. We were interested in this exact same question. Are there differences in presentation, and are there differences in surgical resilience, and are there differences in complications profile? And this concept of surgical resilience isn't something that we've necessarily explored as a specialty, but I think that there's some data that shows that that concept, surgical resilience, and how you measure it and how you track it can be sort of tied into frailty, can be tied into convalescence, can be tied into complications. So what we looked at over 150 patients who underwent adult spinal deformities correction. We had almost an even smattering of men and women in the study. And the primary question was, are complication rates different? We looked at the radiographic parameters at baseline, and very similar to what you see in the pediatric population, the adult population females had slightly worse radiographic parameters compared to the adults, but it was not clinically significantly different. There was a trend towards different, but it wasn't different. But when you look at some of the psychosocial parameters, depression, affective disorders like anxiety, those tended to be worse in females. When we looked at the patient-reported outcomes at baseline, so we looked at pain, we looked at disability, we looked at quality of life, we looked at cognition. All of those scores also tended to be slightly worse in women. So we went into the analysis assuming that women then, or female patients, were going to have worse mechanical failures and worse PROs compared to men after reconstructive operation. And that did not turn out to be the case. The degree of functional improvement from women after surgery was superior to men. So there were no differences at 2 years after surgery, which means that if they started off at a worse level and there are no differences at 2 years, they actually showed a greater degree of functional improvement after surgery. And there were no differences in the rates of mechanical failures between men and women. So it really shows you that the outcomes, the surgical outcomes, certainly what that suggests is surgical outcomes are similar between male and females, although the female patients tend to have slightly worse radiographic parameters. Now, when you look at the concept of surgical resilience, it's something I'm studying in the laboratory now. And this is work that came out of Iowa looking at really in vivo studies where they were looking at testosterone and its impact on convalescence and certainly on outcomes. And what we found, just anecdotally looking at some of the preliminary data, patients who have higher levels of testosterone report less pain after surgery, have better rates of convalescence, and have shorter length of hospital stay. So there's this concept of surgical resilience, how you measure it. We don't have the perfect biomarker. We are leaning towards testosterone as a potential marker for that, but we don't know. But there's something there, but we don't know what that biomarker might look like.
Wow, that's interesting. I mean, do you have an idea as to why this is the case? I mean, are we going to start like checking everybody's testosterone before surgery? I mean, how's that really going to work out?
Yeah. So couple of the things that we're doing in the laboratory is we're collecting blood samples before surgery and at several time points after surgery. And we're looking at several genetic markers. We're looking at RNA sequencing and some other things to identify this milieu, or what I call this milieu of inflammatory markers that might predict which patients might convalesce better after surgery. It could be that testosterone may be a marker for something else that we are not measuring, that we are not seeing now. So I'll give you a slight example. When I was at UT Southwestern, we took 40 patients who had adult deformity surgeries. We had baseline markers in addition to very comprehensive psychosocial evaluation of PROs examinations. And we have blood markers after surgery. And what we found in that preliminary study for patients who have higher levels of IL-6, IL-8, and TNF-alpha, so these neuroinflammatory cytokines, were more likely to have poor pain control after surgery, longer hospital stay, and challenging problems with convalescence after surgery. This is similar. A similar story has been told in other subspecialties, right? If you have high levels of baseline inflammation, you're more likely to have a cardiovascular event. You're more likely to have things like Alzheimer's. You're more likely to have things like strokes. So what this says to me, this preliminary data, is that if we can identify patients, if truly inflammation could be a biomarker for surgical resilience, if we can identify patients who have high level of inflammation before surgery, there might be a therapeutic window to intervene prior to your operation to improve their postoperative complications profile. So that data suggested that there might be a biomarker. The problem with that design, Terry, is that we use a candidate gene approach. So we picked 4 or 5 cytokines, and you could imagine that we're missing thousands of others, which is where the work is heading towards. So I don't have an answer as to what that magic biomarker might be, but I think we're getting a little closer to telling that story.
Wow, that's really exciting. I mean, I can't wait to hear your results in the future. Wow. So, anything else to add on differences? I think that it's interesting that we might have thought that one sex versus the other might have done a little bit worse, but I mean, it sounds like the results of your studies have not borne this out. Any understanding as to why this happens? I know you were talking about surgical resilience. Are we saying that maybe females are a little bit more resilient than males?
That's an interesting question. That's a bit of a stretch. I don't know that we can say that. I think what this says in my mind when I look at results like this, it says that for the appropriate patient, independent of gender, that we can help them. That independent of gender, we can help them. Now, the nuances that I think that we still need to tease out is this concept of frailty. So we know frailty affects outcomes. The question is, are female patients more likely to present with very advanced frail states compared to their male cohorts? You have issues of sarcopenia, right? Women more likely to, because they have smaller paraspinal muscles, the sarcopenia affect both sexes equally. And if you think about sarcopenia, and what happens as we get older with the loss of extension so we think about how we lose extension versus flexion. We lose extension at a much faster rate than we use the ability to flex. So if you have weaker extensor muscles, sarcopenia, frailty, you may be more apt to developing things like proximal junctional failure.
Okay.
You can stop in the lower thoracic spine. So I think that there are several questions that we still have unanswered. Is it purely biology, right? Or is it biology that plays into concepts like frailty? And what can we do as surgeons if there is indeed a sex difference in the rates of frailty, in the severity of the frailty, and so on? What can we do as surgeons to sort of optimize the outcomes for female patients? But as it stands, the data doesn't bear that there are any differences in the patient-reported outcomes or the mechanical failure rates between men and women.
Wow, that's amazing. Well, look, man, thank you so much for joining me. I mean, I'm sure our viewers will learn a lot today. I certainly have, and you've given me several more questions that I want to ask, and I think I'll ask you off air. I mean, it's amazing stuff. Thanks for coming on. And this is Scoliosis Awareness Month, and so this will be airing next week. And really, thank you so much for joining us.
Thank you for the invitation to share this, and it's been a pleasure speaking with you. And thanks to the SRS.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.